I was in the research team and a student at Dr. Moon
Yeah.
2013, and
Okay, we are live.
yes. So
Okay.
I learned from him and I developed a lot of things that he said it works this way or this way, and I make it in another way, and some of success I have. So
Inshallah.
I am honored and privileged to be with you today. Our title is Marpe Assisted by Perforation and Asymmetry Fascia. As
Thank you.
Andy,
Thank you
I can
all for joining.
thank you.
Uh, Today we have Dr. Abdul Hadi Kawaiya from Aruba, and who doesn't know him? I think he and Marpe can be used as synonymous word. Dr. Abdul Hadi, because you have placed so many Marpes, like it is just amazing, just amazing. And your last lecture also, people have enjoyed it like thoroughly, because I got so many feedback from people that he was too good. Thank you again for taking a second part of Marpe. And today you'll be talking on asymmetrical faces and Marpe, and whether we can place a Marpe in the mid-palate and suture or not. And if yes, then how to place it. So we will have Dr. Abdul Hadi Kawaiya from Aruba. He knows four language. I just learned from Dr. Khalid Mohammed, right?
Yes, sir.
That Dr. Abdul Hadi
Arabic,
can
English,
speak
and
in
French.
Arabic,
This is
English,
common knowledge.
French, as well as I
It,
think Spanish
because
also, right?
yeah,
Okay, so amazing, good. Uh, he studied from Syria, France, and then even from US, and then he studied under Dr. Giorgio Fiorelli as well. And he has many presentations in the world. Thank you, Dr. Abdul Hadi. Thanks
thank you.
again for getting our invitation and just giving a talk here. And then we have two eminent uh, panelists today. One, Professor Dr. Ashraf Atia from Egypt. The Professor Ashraf is a professor of orthodontics and former vice president of Al Azhar University, Egypt. Thank you, sir, for joining in. It's an honor
Thank,
having you here.
thank you. It's an honor to me to be with you today. It's fascinating how Corona connect us today. Thank you for inviting me, Dr. Ajay, and thank you for Dr. Abdullah for your lecture today. Thank you.
Yeah. And then we have young and dynamic Dr. Khalid Mohammed, also as a panelist today. Thank you, Dr. Khalid. Dr. Khalid is an assistant lecturer of orthodontics at Al Azhar University and member of evidence-based dentistry unit at Al Azhar University, Cairo, Egypt.
Thank you very much.
Pleasure having you here. Thank you for
Thank you. It's an
joining.
honor and pleasure. Thank you very much.
Yeah. So without wasting much of a time, let's start with Dr. Abdul Hadi's lecture. Thank you.
Thank you. And I start right away
Yes.
to, okay, so when you ask me, when you do perforation, doctor, I do perforation in the palate. When I need assisted, I need more help to open the suture. I do perforation when there is a torus palatinus. I do perforation if the patient has severe apnea over than 30 AHI, apnea hypopnea index. I do it sometimes for accelerated technique to get accelerated results. I do it when I have polyp nasal. I do it when I have hypertrophy nasal turbinate. So in these cases, I do perforation. What is the advantage of using or doing perforation is short activation time, results spontaneous, and patient feel the opening of the nasal airway right away. So disadvantage, some patient complain about pain. We give them ibuprofen 400 milligram for 1 day.
Dr.
Oh,
Abdul Hadi, can you just do the slide show?
what you mean slideshow?
Okay, just click on that green button, slideshow. Can you just see on your screen, or you see on the top, there are on the right, extreme right side, there is something called play, slideshow.
There is more. I push on
Or
the
else
more.
no, or you can check the bottom line, first, second, and third one. Can you just see on the bottom line, first, second, and third? First and second, there are 4 dots, and then there is yes, just next to it, next to it.
Okay.
Perfect.
It's good now.
Well,
It's automatically by that, or
no, I think your slide should come because this is. Can you just take your cursor away from there after clicking?
I take my cursor away. I don't have a cursor here. It is a laptop.
Yeah, but I can see, or you can just because your slideshow is not visible. Your entire slide as well as all the slide numbers and everything is visible on the other side.
Oh, it's not visible?
Slide is visible, but along with the slide, next slide is also visible on the left side. That's fine with you? It's fine.
The left side also visible?
Yes.
It's okay. As much you can see what it is.
Yeah, it is visible. Okay, let's go ahead. No problem.
No problem. So this is my patient, crowding, and his complaint is he cannot breathe from his nose. So here I am not orthodontist to align the teeth. I am here somebody to help him to breathe better. And I want you to download also this app store, which can show you 3D, and it's free if you find it. Okay, and it help you. So this is his palate. I start by perforation. And I use this needle. This needle, we use it for the dentist.
Dr. Abdul Hadi, your slide's not moving. It is at the advantage only. It is not moving. Next to the next slide.
Okay.
Can you just stop sharing and then start sharing again?
Yes, right. Stop sharing. Okay. Now share again. Share. Do you get it?
Wait, let me check. No, nothing is visible. Only white screen is there.
Okay, let me check.
No problem. Take your own time. Yes. Perfect. Perfect.
Okay, now you see the second page?
Yes. Now everything is visible. Perfect.
Very good. Okay, so this patient, James, and this is palate. You see there is a little bit torus on his palate.
You were talking about some app. Can you just go back to that because it was not visible? Okay, Bellews 3D.
Bellews 3D.
Okay. Thank you.
Okay. And this is his palate. So I do perforation in his palate, slow speed. And I use this needle, perforating needle that we use as a dentist to help to have the truncular, to have good anesthesia and truncular. They are needle perforator. And they are very cheap. And here I give you idea about the perforation that I did. I did the 3, but there is maybe 5, I think. And there is a small perforation at the side of the palate. Then I install my Marpe. Right away, this is the needle perforator. And right away, I start activating.
So we are today with another case of Marpe.
And here you see I activating.
Between
and you see the progress of activation. I continue activating until the patient said that he feels too much pressure.
Okay, that's okay. I think that's enough.
And what else do you feel?
So now I ask the patient, what do you feel? I breathe again.
All right.
After 30 years.
After 30 years, he starts to breathe from his nose.
Then I can breathe this side.
Oh, that this side start to use
Yeah.
to breathe it from your nose
Correct.
before you breathe only from your mouth.
From the mouth, yeah.
Yeah. So now the right side, the nose cavity it's open and you feel it open
Yeah.
and you can get to breathe from it.
And I feel it from here going back.
Wow. So we got a revolutionary spontaneous result.
I feel
Right.
this one also.
Yes. We got.
So the question is, if you are fasting for long hours and you drink cold water, you feel the water going through your body. The same things, he doesn't breathe from his nose for a long time. And then when he starts breathing, he feels the air running in the airway. So this is his X-ray, and I show you before the suture was closed, and right after 5 minutes, you will see the suture start to open. So this is the initial X-ray. And
this is the initial X-ray, and you see that this is all the turbinate, and you see that the left.
So you see the turbinate are well developed, and you see the mid palate is really closed.
Going up. Here you are. Then we go back down, 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 down. You see again the turbinate. You see the tortuous suture here in the middle, very wide.
And this is the CBCT. And now I show you 5 minutes after initiation of activation, we start to see this black line. I can zoom it to show it to you. So these are the Marpe screw or the Marpe tab, and in the middle you see this black line there. This is with a little bit focus. Here you are. You see the black line in the middle, tortuous. This is only 5 minutes, and this is what it was before, and here is after. So this is a video to show after the suture how it is open.
This is also all of and then we have the suture in the mallet open by the Marpe. See? You
So
see this black line in the middle showing the opening.
so that's why the patient said that he start to feel breathing, and this is the CBCT again showing the Marpe inside his mouth, the panorex, the Marpe again, and the airway. So during the perforation, the patient came to me and he told me that he feels something inside his nose, sorry. And you see, this is the Marpe. These are the activation. There is around 2 millimeter, 2.5 millimeter of each side. And you see here, this is a perforation that the patient feel. So I put something here, a cyanoacrylate. The periodontist uses this as stitches to close a flap. So I use it as periacryl, high viscosity. The name is cyanoacrylate for superior control. So this is cyanoacrylate or periacryl for periodontist, is to close that small perforation or small opening between the cavity, mouth cavity, and the nose cavity. Another patient, his name is Aron. He came from another orthodontist office, already the teeth extracted, the first premolar. Then here is in the model, I trace for you the area that are risky, very risky. It's a papilla retroincisive. And the areas that I don't recommend there is any screw or tad in it. And this is the limit anterior of the Marpe, which is a mesial line, virtual mesial line between the first premolar. And safe area, I trace it with the green. The perforation, I trace them. And the acupuncture around this perforation, I trace them. And I put for you the limit, posterior limit of the Marpe. What are the other very risky area is the maxillary antern arterial, which is behind, very back. So the risk is almost zero, unless you attend it to make hole in the papilla incisive, or attempted to cut the maxillar and turn artery, there is no risk to do this. So this is a map of it in all direction. And here is the position of the Marpe. It's very important that the position of the Marpe, the middle of the Marpe pass by the middle of the suture exactly. Not to the left, not to the right, exactly in the middle of the suture. And very important thing that the palate is narrow. You see, I cut part of the hands of the Marpe. Rail may cut to fit better. You see, it's cut here and here. Its Marpe should be centered to give equivalent force to both sides, arms, and give exact force to the suture. Arm should be at least 1 millimeter away from the palate mucosa, because when you expand, if it is sitting on the mucosa, it will be entering inside the mucosa. And even in the lower, minimum space 1 millimeter to clean under and avoid pressure on the mucosa. So these are the criteria that you should tell your lab about it, or you do it yourself. So when inserting mini implant, it should be in the center, the socket, in the center of the socket. So when you put this stud, it should be in the center of the socket and perpendicular to the palate. Out of the center may make tad bending. You will hear metal screaming. So when you are entering your tad inside your Marpe, if you hear metal screaming, it means that it is not in the center. They remove it again or put it back 5, 6 turn and go back to the center and then insert it again. You see the space under the Marpe to help to clean and not make pressure on the mucosa. Here is the perforation and the acupuncture, and we put the patient, and here is a airway before, after, 5 minutes after. Then we can see also the opening of the suture. It's not there. The video here, video J1. Okay. Again, the patient will explain, will say that he feel better in breathing and he feel better in his case. Here, I think the suture is opened a little bit here somewhere.
Voluntary Aron kung abay.
So this is a person.
Squares ko MRP ta punin.
So he explained about his experience, but in Papimento language. Here is another case where I used surgery also to expand. But this guy was a very heavy snorer, like he snored like a horse. So, and what I did perforation, not only in the palate, but also in the buccal. And I make for him a flap. You see, there is a flap here. And I open this and I put, make a tunnel. I opened here, here you are, you can see the flap and you see the tunnel that I make until almost upper nasal anterior, under the ENS. And in his palate too. And I gave him the polysomnography, that home test sleep, to see how much he is sleeping. And because he is open by 2, I gave him, oh, I am going back. Yes. So this is a suture. Oh no, this way. I put for him a tongue habit control on his palate. And here is a video next day, I think.
Yes, today we are with Albus Schedule. Elvis is 50 years old almost. He has the choice. He has the teeth almost aligned, but he has open bites and the tendency. So this is Elvis. How are you?
Fine, thank you.
This is right away after the surgery.
I make small flap and between the two central until the end of the frenum, I did a small perforation, 2 millimeters deep,
And you see the anti-lung
is almost
habitat,
identical.
and you see the opening.
So that's make 2 millimeters of pressure. Open bite, he has the tongue habit one.
It's a video of 15 minutes, so I want to make it shorter. Anyway, this after right away, and he is air conditioner installer. So he went right away and he worked and he installed, he told me he installed 3 air conditioner. This is the next day.
No. Okay, and
Oh,
how long it takes the whole procedure? The whole procedure is 1 hour.
so I did the flap and I did the installing
The procedure,
the
what
Marpe.
do you feel as the difference? And now I can, my nose open. Yeah. Now I can. You feel you can
Yes,
breathe
better.
from your nose much easier, much better than before.
Yes, sir. Yes.
Okay, very good. And yesterday I gave you a BSG machine to measure the first activation.
Yeah,
We still have another 15, 10 to do, so we did only 10. So
The first day I make the perforation, I make 10 right away.
It's open now.
Very good.
Not 100%, but you open, yeah, 50.
Now he's speaking another language. And this is
Yes, good morning, bon dia. So today we are 24 hours after
24 hours after what's happened.
the first night.
That was better. I sleep more than normally.
How long your sleep was? 1 hour, 2 hours, 5 hours, 20 minutes every?
No. Normality was 2 hours, and yesterday sleep 4 hours, 5 hours, and
4 or 5 hours
Yeah.
straight,
Yeah.
non-stop.
So already only
How
1
many
day
times you
and he
wake up?
start to feel the progress.
I.
So he speak now in his own language. I show you his Marpe with the habit control, and I show you the activation. And I show you here 2 days after.
Today, after 2 days, tell us how you feel.
Oh, okay. I feel better. The nose go open a little bit, but it's today, not too. But I sleep more, and it's good. I don't dream not yet, but
Yeah,
I hope
because I told him you will dream maybe after 1 week or 2. And because he is single, he may dream genital dream, which is good for him. This is my brother. He lived in Amsterdam and he came to me for visit 4 days and he has heavy snoring. So we show you his CBCT. He has a big turbinate on the left. And these are the instruments that I use. Topical anesthesia, of course, anesthesia and flap and band removal and band pusher and the dental pipe. And this is the Marpe with the mini screw and with the activator. And as I told you, I use a steppy dent. The steppy dent is a kind of perforator needle. And here is everything is ready to start. And this is the motor to place the TAD. And here is a perforator, needle perforator. I do start on him. And this is the needle after the perforation to go inside his palate before they use a big perforation. So small perforation with the needle perforation, and then small needle inside the palate, and then using big perforation with diamond and cement, diamond burr. I have those on my Facebook. You can see which the pair is exactly. And after I finish, I use laser to stop any bleeding, if there is any bleeding, because I want it to be clean when I insert my Marpe. So I put the laser on it. And then I insert my Marpe. You see the opening that I make here, almost 5-6 millimeter of width, of length, and maybe 1 millimeter of large, and 2-3 millimeter of depth. And this is the cement that we use to put my Marpe in. And here it is seated, pushed with a pusher and light. And here is how I use my TAD inside. So I put it in the center of the socket and then perfore the palate mucosa by the screw. It goes right away 1 or 2 millimeter, depends the thickness of the mucosa. And then I rotate. Here, how I rotate the screw and how I insert it. So one finger holding the screw in the center of the socket and the other 2 fingers going clockwise, inserting the screw. It's better to inserting the screw in a cross way. So I start by distal from anterior to the mesial posterior, and then like this. So it's like a cross. Do not put the front one and the alone, and then the posterior one alone. It's better to go cross way. And you see here I am turning, and here I am using a ratchet to turn my final touch, because when I put my screw, I don't go right away to the end. Like your guy who do your tires for your car. He tied the screw, and then he make the car down on the floor, and then he tied it more. The same things. I tie the screw, and at the end I use this to tighten it more to be in perfect place without tickling or shaking. And here I show you the photo of the Marpe with perforation or with the surgery, microsurgery. And here I start the activation, 1, 2, 3. And here I show you the activation. You see the activation now. I have almost 3/4 of 1 millimeter of each side. I continue the activation. How many activation? Usually I start with 6, and then each one I ask the patient, do you feel pressure? How much pressure? Too much pressure? Until the patient said, yes, I feel really pressure on the both sides. Then I stop. Because I find it's different from person to person. And I find it the slimmy piece of people, the people who are slim, they cannot take too much pressure. And the people who are fat, they can take much more than the others. Here now I have almost 1/4 or 2 millimeter, 1.5 millimeter on each side. And I continue. Here you are. The patient, he use another app. I want you to take that on in notes with you. It's named Snore Clock. The Snore Clock, he put it beside his head when he sleep. It records how many hours and how many time he sleep. So I want everybody of your patient, if you treated him for airway, ask him to have a Snore Clock. There is another app called Snore Lab. Please take this photo if you need it. Snore Clock or Snore Lab. Here I show you more. The second day I did more turn. Almost 5, 6, 10 every day, 3 morning, 3 afternoon. And this is after 4 days. So after 4 days, because he is leaving back to Holland, I cut the Marpe arms in both sides, and I remove it. You see left side, right side. And now is the Marpe without any hands or arms. And I put the ligature. You see here, I am ligated it. Why I ligated it? Because in a short time we open. If we do not ligate it, the force of the suture to close back, it may turn it back. I see some cases it turn back, not 100%, but some part. So to avoid any relapse, I put a ligature on my Marpe in the middle to avoid it is moving. And here is the ligature final. You see it. And then I ask the patient to put a wax on the roof of his palate to cover this Marpe and to continue his life normal for another 3 months. Here is the Marpe, cut it, and here is the ligature. And I asked him after 4 days, what is his opinion? So he showed me his snore clock. He was almost all the time, the noise was very much. So I show you here, it was almost 68, and it goes down 19, 6, 5, 15, 15, 18, 5, 1, 0. So from somebody that heavy, that's snore very heavy, like a train, I couldn't sleep in his apartment. And he will tell you his story in a few seconds. And he sent me this. He said, okay, doctor, I buy this gum and I find it very good to put it in the roof of my palate, better than your wax. So here is my brother or the patient. And I can show you.
We will follow up the case that we did 4 days ago.
So 4 days ago, we follow up and we put the suture.
Ask him what is his opinion, what's in a way that cover.
And put a wax to cover it.
I was a teacher and she go to bed, and when I come back, the following treatment. So before treatment, what was the problem? Can you zoom to his face? I was suffering from snoring for 30 years or more, and that made me big problems for me till you invent this way of.
So was that affected your matrimonial life with your wife? How was it?
I was sleeping at night and she sleep at day when I go to school because I was a teacher. And she go to bed, and when I come back noon, I wake her up to wake her to her life. That was very big problem with her. But she was patient, and I sleep at night and she sleep at.
And here is making us hearing his snoring before and after. You can see that video on my Facebook. This lady, I started her 10 days ago. Her name is Jacqueline, and she works at the church here in Aruba. And she referred to me by a pulmonologist, a doctor specialist of lungs, Dr. Selina Koch. I start her case. This is her panoramic. She was referred to surgery, but then she find no surgeon in the island, and she asked me what I can do the best. So here I show you the 10th of June. I start the 10th of June, 2020, and we are 21 today, so 10 days ago. And this is a Marpe inside her palate, you can see. And you can see also the splitting of the midline. Now there is a little bit space. There wasn't space before. And if we go for her lab, snore lab app that I told her to download it, you see this is Monday, the 15th of June. It was 65. Then Tuesday, 19. Tuesday afternoon, she slept 1 hour, 6. You see, at night, she slept 4 hours, 36 non-stop. She got 19. At afternoon, she slept 1 hour, 7 minutes, and she got 6%. Wednesday, she got a 29. So I was surprised. Why the number increased? And I asked her, why the number increased? Is there is a train pass by your house, or you have a dog in your house or something beside your house? She said to me, no, my husband sleep beside me and he snore. I told her, kick out your husband out of the room. I want a perfect recording. And then next day she came with 15. And yesterday, or before yesterday, Saturday, the 19th, Friday, she came with 5. So this is result that we get in only few days. And I want you to listen to her, how she feels.
Well, actually, my lung specialist is the one who spoke to me about coming to Dr. Kawara to put the Marpe in my mouth. She explained to me a little bit what it is. And then I came here and we started the job. And in the beginning, the first day when I came, my snoring index was 68. And then like that, it went lowering. I had a lot of problem with my breathing. And in a few days already, you could have felt the difference. And yesterday, for example, my index went to 5. And
From
I feel
65 to 5?
from 68, it went to 41, then it went gradually, yes. Within like 10 days time, it reached to 5.
So how many days you are since the day that
And I asked her about the splitting.
So since already
You see the space.
and we see
That's the split. Yes, yes.
So tell us about the crack. What do you feel when the maxilla opens separator tube?
That's a little bit of pain. When you feel it crack, you hear like tuck, and then you feel like your teeth is opening, you know, and you feel something between the gum and the nose. An experience of, I don't know, a pain in between there. That hurts a little bit, but it's not a pain that you need to go and take a injection, a painkiller or anything like that, no.
But when you hear that click, you went to the mirror and you check your teeth, what you find?
I was in the car. So then, but it was like gradually, it was opening gradually. And then when I saw, at the afternoon, I saw the split.
So this is what we have to tell our patient, that we expect that you will have split and you will feel a kind of a pressure in between your root of your centrals up to your nose. And this is what she gets. So I finish with my first, and I want to present you my second lecture. Are you following with me now, the asymmetry? Everyone is there, Dr. Ajay?
Yes, all are there. I would request everybody to raise their hand so that Dr. Abdul Hadi can see. See, people are raising. Wow, amazing.
For the interest. And now, this case, this case that I want to present to you is a case already finished by 2 other orthodontists, and they refer him to surgery. It's a complex, heavy case of asymmetry. I want to speak a few minutes about what is asymmetry, and then I show you the case. So asymmetry, I show you the 3 acts of the space, and you have to look on the base from the chin, lower jaw. The asymmetry may be skeletal, dental, alveolar, or functional, and the asymmetry, it may affect the acts of the tooth, buccal, and make distal rotation, etc. The diagnosis is and the treatment concern should be attended by orthopedically, Marpe or for facial mask, headgear, or by growth if he is young and functional appliance, and mandibular repositioning. So we have to reposition the mandible that is deviated to the left to bring it by using functional appliance or triad gel and elastics. So here I show you again this app. You already see it, but I want to show you myself on the left and the right. And we have some introduction that cephalometric in this case of asymmetry is not very effective. So you cannot, based on cephalometric, to speak too much about the asymmetry. However, the 3D phase can be viewed from various angles with accurate measurement in length, angle, area, and volume by using a non-invasive 3D surface imaging technique. So I want to show you my patient text here. You can see the white is a straight line and the blue how it is. So my patient is deviated this way. So I have to bring this chin as much as possible to the middle. And also if you look to the Killian, pi Killian line, the tulips line is also canting. The occlusion is also canting. And also starting from the Frankfurt, that etiology, genetic, aging, lifestyle, trauma, dental work, stroke, palsy, juvenile TMG, etc. And the facial cephalometric is important to measure. The lines that we use, glabella, pronasal, sonasal, labial superior, stomion, labial inferior, menton, all these to determine the midline. What is the treatment planning? So we have to treat this patient of asymmetry in the 3 direction of the space. It's always considered 3 direction to correct him. The treatment of the asymmetry in the transverse way and correcting the lower midline as much as possible, correcting the posterior transversal asymmetric caused by the shifting, calculating how much is the asymmetry. Usually before we use this appliance, which is expansion palate, inclined palate, crisscross elastic, transpalatal arch, lingual palatal arch, quadrilex. Everybody of you know this. But now I add to this mechanic the Marpe and the triad gel. So what is the Marpe and triad gel? We have expansion hyrax and we have expansion with the Marpe, maxillary skeletal expansion. The differential anchorage, so I need different force. It is because it is asymmetric, I need a little bit more force on one side than the other side. There is always a variation, and there is always a difference in the size between the active and the reactive unit, which is allowed to have some pressure. So differential force system, it is a force system applied. So we have to know what is desired and undesired effect of the differential force. So the occlusal forces can either support or reduce the anchorage. Free anchorage by using a teeth to be extracted. Skeletal anchorage, TAD and Marpe. Asymmetric expansion plate is also as only a minimum force is required for uncontrolled tip. It's very likely that such a force can also displace the reactive unit, but an equivalent force. So before, you remember, we use this to correct a kind of asymmetry. We use elastics, but precaution and adding extra force to limit undesired movement, because there is a lot of undesired movement by using the crisscross elastics. You have to watch, but now with the help of the TAD, we can minimize this movement. We can use lingual transpalatal arch, TPS, or quadrilex also to correct this midline deviation, and TPS to correct, or the headgear, variant of headgear in case of asymmetry force. And the cantilever, we can use cantilever to correct, and asymmetry force by displacing this cantilever. This photo from Dr. Giorgio Fiorelli. And also, when you place your braces, take on consideration that you have here a canting, so you change the position exactly of your teeth to help to correct the canting. So this is my patient. I make this a small introduction to help you to see what is asymmetry. So this patient has a braces 5 years, and he come for a second opinion. So we make initial and we start DB in December 2019. So this is a photo from the referring orthodontist. He referred him for surgery, and you can see here that the chin is deviated to the left. You see here that the midline is deviated to the left, to the right. No, sorry, to the left. Yes. And here is his faces. I show you his faces, the face, and the deviation of his chin to the left, the asymmetry, the Frankfurt, the middle sagittal plane and the chin. Now, if I take this half face of the right side and I want to have a mirror of it, and this half face of the left side and I want a mirror of it, it gives me these faces. This is the right side face and this is the left side face. So that gives me idea how much I have to work. He has B bimaxillary prognatism, so both the maxillary and mandibular are forwarded to the Frankfurt. This is a dental analysis. This is a case you see before I started him. So the midline is deviated. And this is when I want to start. So I remove everything and I make my initial records. Midline, asymmetric, the canting of his smile and his lips to the chin. So the chin is deviated to the left. The maxillary is canting down comparing to the P-pupillar line. And here I put the point and you see that more I go down, more the point is deviated from starting from pronasal, LS, menton, and the Killian line is also canting. The panoramic showing me that the ramus on the right side is longer than the left side and it is thinner. So, and if I look to the occlusal plan, I see that the right side and the left side, you see there is canting. So I have to intrude these teeth up. Then I have to shift this chin and this lower jaw or to the right. So I have to bring it to the right and I have to intrude this area. So my objective of treatment is expanding, intrusion, and the translation. So correction of the mandible rolling, the arrow repair the direction, represent the direction of the correction of the asymmetry. So this is the direction of the asymmetry. Of course, you take a basic X-ray and cephalometric X-ray showing the difference. Here is the axis and it shows you this is longer than this and this is canting again in the CBCT. Here I make a sketch also to show that, okay, this, if we align this, the upper teeth and we align the lower teeth. Here is from Oxford, I take this picture showing that the deviation or asymmetry when it is 2 millimeter is difficult to distinguish it, but more it gets, now here it's 8 millimeter and you can see it. And my patient is more than 8 millimeters. So we have to do decompensation. What is decompensation? First, eliminate dental compensation that is done for this asymmetry. Intrude of extruded maxillary molar of the non-deviated side. So the right side, I have to intrude the extruded maxillary molar. Lingual typic of maxillary molar in the deviated side. So I have to make them lingual typic. So I don't need too much expansion on the deviated side. Move the upper dental midline and middle of the skeleton. In the mandible, the dental midline is set to the chin of the mandible, moving and inclining the mandible incisor to deviated side, which initially were inclined to the non-deviated side. So here is a sketch again, the upper teeth and the lower teeth. Basic X-ray And we take here the TMG, and I see in the TMG that the right condylion head is larger than the left. However, the right ramus is thinner than the left. So if you could see the space, your right condylion is bigger than the left. And if you see the space also, increased joint space of the left, possible resorption of the right condyle. So possible destruction of the right condyle. So you see here, and this is a X-ray of photo before the X-rays for the airway and atomic slides. This is again to see the axis and the deviation. So now I have two mid-sagittal of the, if I take the mid-sagittal of the mandible, you see it is deviated. This is a left and this is a right. Or I may take the mid-sagittal of the face and I see that it is deviated more to the left. Cephalometric, it gives me information about the skeletal. I have maxillary protrusion, mandibular protrusion, chin protrusion. And my plan was treatment 16 months. I have to put TAD in the upper, lower, and correct the asymmetry. The question is, here is we start. Patient, I put Marpe. So I start to expand. As I told you, because I want to fit the lower jaw now in a new position. So I expand the palate. But I need more expansion on the right side than the left side. And I need intrusion on the right side and not the left side. So you see, I add the two TAD on the right side and I add elastics. So there is elastic to help to shift the lower jaw. So from the left side, my elastic is class 2, and the right side, my elastic is a class 3. And I have elastic to intrude this right side upper molar from the buccal to the TAD and from the lingual to the Marpe. You see the elastic is going to the Marpe on the right side. So you see the elastic and the intrusion. This is the intrusion, and this is to help to correct the shifting. In adding to expansion, so I have expansion of the Marpe. You see there is 2.5, 3 millimeters of each side, and you have the action of the elastics to intrude this molar only on the right side. Thank you. See, my wife, she make me coffee. Break, 1 second break. You see the design of my Marpe is behind the virtual line joining the first premolar, mesial of the first molar, and in the front of the distal line joining the first molar. So now there is action to intrude the right side of the maxilla, and another action to make the lower jaw shift it to correct the midline. And here is the action. And you see the occlusal plan started to change. So I have class 3 elastics on the right side and class 2 elastics on the left side. And I have elastic to intrude. This is a class 2 on the left side. Now I see him after 1 month, I think, or 2. Let me see the first date. It is here, the 26th February 2019. And now 25, so exactly 1 month. You see, after 1 month, I start to see opening and disarticulation of the right side. Now the right side, the teeth do not touch. But here is action. And you see, I started from the canine up to the second molar intrudes. So lateral displacement and proclination Patient who present with midline deviation, a lack of space for canine will be benefit from transversal and pronation movement. So we have to expand to do it. And this is a midline correction by cantilever. These are helping. And this is a result of asymmetric posture of the mandible may be established by elastic class 2 one side and class 3 in the other side. Wow, this is April, so 2 months after. Can you see the midline is getting better and the profile and face of the patient getting better? You see his face, the chin is starting to be more to the middle. When he came, then I decided that I need no more the right side, left side to be attached. So I removed the left side band. I kept the right side band with the Marpe because I don't want to lose the result of the expansion here after 2 months. And I continue my elastic to intrude my molar. So I bend these arms of the Marpe to help me to have elastic going from first and second molar to the arm of the Marpe in the palatal side. I have in the buccal side also elastic that is, or metallic ligator that goes from the premolar molar to the tad on the buccal. So I still continue intruding the right side. And this is another technique here. If you have a Marpe, don't throw it. You can use half of it to intrude some case and some teeth. So this is not case of my patient, of this patient. It's case from another patient where I have to intrude the molar. I installed half of the Marpe with 2 screws and I attach elastic from the bottom to the tad Marpe to the Marpe. So here you can see that also I installed between the teeth another tad in the lower to keep the space of the molar down. I don't want that I intrude the upper molar and then the lower molar follow them. No, I want to keep this space to help that the lower jaw take his place. This is 25 of July, 6 months after. I continue by putting elastics, joining them to a tad in the upper and in the lower right side and to the palatal side. So I continue, but can you see the midline is almost there? So if we continue, and this is a mechanic, you see I am protruding or taking the upper, correcting the upper midline with elastics and intruding the molar in the upper and the lower right. Here is a palatal side showing that I continue to intruding with keeping the expansion of the palate and traction to correct this midline. Here is August. So 1 month again after, we continue aligning these teeth and intruding and keep the intrusion. So here we are in December. You see his face is starting to get better. The teeth are aligned and I am at the midline. I can show you the profile, the occlusion. Do you see the midline is now in the middle exactly? And here is his face. Show you, if you look to his face here before I start and you look to here, you see the progress. It's not photo montage. It's not Photoshop. This is what is the reality. And this is his teeth before and during the treatment. We can see the midline going from shifted to the left, the lower, and is corrected. Here is the usage of continue using class 2 elastic on the right side and the class 3 elastic. class 2 and class 3 elastic on the left side. So here is a class 2 and here is class 2 and here is class 3. So here is class 3, sorry, on the right side, and here is class 2 on the left side. The arch now it is symmetric, almost. The teeth are aligned. Do you see this step that I made is to continue keeping these teeth up and continue having this occlusal plane straight. So in case of using the class 2 elastic on one side and class 3 on the other side, that produce a biomechanic system result in a series of side effects. The occlusal plane will change its inclination in both the transversal and sagittal plane of space, frontally tilting. That's why when you use the class 2 and 3, be sure that you have another adjuvant system, which is the TAD, to keep it the result that you want. Here is the panoramic showing the TAD that I put here to help me to intrude the molar. And here is a CBCT showing his jaw just after. You see the midline is good and the occlusion. So on both sides, right, this is the right side. And this is the left side and the basic. So yes, now his teeth is straight, but he still has the chin in the lower. It's still not symmetric. And this is something that I cannot correct, but this is avoiding for him a big surgery that the sagittals, L4-1, and the other, and genioplasty. But now what he left for him is to do mini genioplasty, and his face will be more symmetric. This is his face with a smile. You can see a little bit more. This is his profile. He's still in the treatment for another 6 to 8 months. But if you look now, we still have a deviation of the menton of the lower of the chin is not perfect in the middle. If you go and take a line or a mid-sagittal line. For this, comparing his case before and after, I think that for somebody who doesn't want surgery, we help him a lot and we make it a mini surgery. So now what he can do, he can add a little bit of a filler here if he wants, he doesn't want surgery, or he can make a genioplasty surgery. And I here have a little bit about what is genioplasty surgery. It is very simple surgery. You can see here. They make a little bit incision at the chin and they remodel the chin in a way that needed to be done, and then smoothen it and then they close it. So it is mini surgery and the risk is almost nothing. Or as I said, they can have a filler for that. I thank you very much for your listening to me, and now it's open for a question. Dr. Ajay, I finished my presentation.
Thank you so much. Okay, we have many questions. I request Dr. Khaled and Dr. Ashraf and Dr. Prasad. Okay, thank you. Dr. Prasad, you can also join in. We have Dr. Prasad Mandava, Professor Prasad Mandava from India.
Welcome.
Almost our permanent panelist, a good friend, and a very good clinician and professor. Okay, there are a few questions. let's start from one by one. Dr. Abhiraj is asking, sir, what kind of metal TED was used? What was the dimension? What was the dimension and what kind of palatal TED was used? I think
is 9 millimeter of length and 1.8 of diameter.
Okay.
No, 11 millimeters of length and 1.8 millimeters diameter. 11 millimeter length and 1.8 of millimeter of diameter.
Okay. Then there's a question from Dr. Amruta. Dr. Amruta Chandak. Sir, what is the maximum diameter of the oroentral communication that can be closed with periacryl? Thanks in advance.
I think 1 to 1.5 millimeter, you don't have a problem because anyway, our perforation is 1 to 1.5 millimeter of, and it is 2 to 3 millimeters. So 1 millimeter, if you keep it 1.5, I think that is possible. Maybe if it is more, then you have to think about what do they call it, the period dressing things, and maybe that will help, or stitches. I don't go more than 1.5, so I didn't have a problem more than using the cyanoacrylate.
Okay. Dr. Amruta Chandak is asking, so what is your call on upper third molar extraction in patients planned for Marpe?
What is the question is, what if I extract the molar? I don't understand the question.
What do you suggest about extraction of upper third molar for patient planned for Marpe? Do you suggest extraction of third molars?
I didn't suggest.
Okay, perfect.
The molar is not in my way for expansion.
Okay, because you are going transverse, you are not going sagittal.
Yes. Okay. I didn't have any problem with keeping the molar, but sometimes I extract. The guy who has very heavy snoring, that I make him surgery, yes, I suggest to him to do extraction of the first molar. It's not for Marpe, it's because he has another problem, the open bite, and he has other problem of crowding. I suggest that, but it's not mainly for the Marpe.
Okay. What is the activation schedule, Dr. Akshay Mohan?
Activation, usually I start by 6:10. And after 6:10, I start to ask my patient. I do 1 or 2, how do you feel? And my criteria is the patient handling. None of us are the same. And as by experience, I find fatty people, they can handle much more than the slim people. But I don't have like one recipe for everybody. I do 6:10, and then I add some people I went to 10, and some people I stop at 6. And then the next day I do 2 in the morning, 2 to the afternoon for 5 days. So that make another 20 activation. And then I check his mouth.
Okay. And for how long you keep it inside the mouth for stability?
Minimum 3 months after finishing the activation.
Great. And what is the rationale of perforation?
What is the
purpose of? Yeah, what is the rationale of perforation?
Rational perforation, how much is perforation? This is a question.
No. Well, like, why do you do a perforation? What is the reason for doing a perforation?
I do the perforation when I doubt that the expansion will be much slower. I give you example. I have a torus, heavy torus. I have a AHI very high, like somebody who has more than 30. Or I have somebody like my brother, he came from Amsterdam only for the 4 days. So I want to show him result right away. Okay, so people who hasn't breathed from their nose since 20, 30 years, it will be better to go with perforation because you help him as faster as possible and you get confidence from him. The result was spontaneous on that patient that hasn't breathed from his nose for 30 years.
Okay. Dr. Talal Al-Khayal, your question has been answered. What is the size of micro implant and length of diameter? It has already been answered. Okay. What is the upper age limit for recommending Marpe? Like, what is the age limit you recommend for the Marpe? Do you do it for every age of the, because I've seen your patient 50 plus, 60 plus, even
I
last
have
presentation were 70 plus also.
71 patients, and the youngest I have, she is 13 years old. She
Because in
has
last presentation you had shown one lady who was 73 years or 78 years, I guess.
there is one lady 81 years old.
Oh wow.
So there is no limit. Usually we are limited by the osteoporosis to expand the palate, but I never see osteoporosis in the palate. You see the osteoporosis in the big bone, like the hunch, and like the
Upper
feet,
limb.
like, yeah, but not in the small bone. You don't see it, or it's rarely. So when I take my CBCT, I see that density is acceptable, I can go ahead.
Okay.
So there is no limit. I have from 12, 13 to 80, 81, no problem.
Okay. There's a question from Adil Ahmad. In post-adolescent patient where ossification of mid-palate is complete, can we use Marpe without perforation in class 3 patient to facilitate the protraction of mandible? He has written it has to be maxilla. I think he wants to ask about maxilla. Dr. Adil Ahmad. Can I take him online if he's there?
The treating of the case, a class 3 case, most of the time with the cross-bite, we're treating it with Marpe and facial mask, and that gives good results. You don't have to do perforation, especially if the person is young, like 20, 30, you don't have. I said that the perforation is especially for people who has apnea or torus palatin, or the people who are in rush to get results. That will help, the perforation. But if you are in established clinic and people, because I have some patients coming from overseas come to me, and these people, they want a result right away because they are in vacation just 1 week in my island and they want the result right away. Then we do perforation.
Okay. So now the same Dr. Adil Ahmed is asking about, like, if the mid-palatal suture has been closed because of ossification, how is it possible to open the mid-palatal suture, like even after completion of ossification with Marpe, or we have to go for Sarpe?
No, this is a UCLA Dr. Moon experience and his resident. We have shown, and he published many article about that by Marpe only we can split the suture, mid-palatal suture.
Right.
I am in a private practice. I just published something on the medical journal of India, and speaking about apnea and about opening the door. But Dr. Moon has a lot of publishing about that with his school and university, and as a resident, of course. I will publish a book with the help of Dr. Ajay very soon about Marpe, inshallah.
Okay. Dr. Muhammad Asadi. Hello, dear doctor, and thank you for your lecture. Very interesting topics, very professional information. My question is about this case. The ramus condyle are smaller in left side. How did you move the mandible more to right? What about the condyle?
This patient is, when I started, he was 16 years old. So we still have potential of growth in his condyle until 18 or 19. And I try to get benefit of that. And this is why I go with this technique. So the movement is adaptive at the condyle because of also the growth of the patient, not only because of the stress and the pressure that I make. So creating expansion in the palate, intruding the molar, and then the lower jaw go and take that place.
Okay. Dr. Mohammed Anisur Rahman from Bangladesh asking, so can we do Marpe without transverse discrepancy? I guess there's nothing wrong. Like, and why would you do Marpe if you don't have a transverse discrepancy? I think probably for airway he's asking.
Yes, yes, I have a patient that they have perfect occlusion, but they have a very bad Marbe and they want to be operated. Then yes, we can do a Marbe. And even some cases of perfect class 1, we make it almost H to H or almost class 3 to correct his breathing, because the breathing is more important than the occlusion. The breathing, you cannot breathe, stop breathing for more than 3 minutes. You can stop. You cannot stop. You can stop eating for 3 weeks. You can stop drinking for 3 days, but breathing 3 minutes, 4 minutes.
Okay, thank you so much for such a wonderful session, even for the question answer. I personally have one question. When we do a Marpe, what happens is that it's a triangle basically. There's a pellet, and then we can consider our mandible symphysis as the apex of that triangle. And if you see this, so when you expand, any a problem with the condyle, have you ever, with the TMJ or position of the condyle, have you ever come across? Because I feel that if we go beyond certain limit, probably patient might have a clicking noise or there's a subluxation. I don't know. I'm just assuming it. I might be wrong.
The first, the Marbe is different from Hyrax. The expansion is not a triangle. It's parallel to itself. So the palate expand parallelly. And the bone of the zygomatic is open angulated almost 0.6 degree for each 1 millimeters. So don't forget that you are treating a live bone, and the live bone, they have a kind of elasticity to adapt. It's not like dead bone, it's hard, it doesn't change the position. Here the live bone will adapt to it. So for the condyles, I personally, up to now, I do not have a problem with any patient. However, it may be something happened, but I don't find that in my cases up to now. What is the chin? What you said that in the chin, it's triangle. This is the case of asymmetry.
Yeah, asymmetry, yes.
In case of asymmetry, yes, you expand one side much more than the other. That's why you see I cut the hands of my Marbe, and I start doing only one side activation and one side intrusion. So yes, and I said also that asymmetry force, always there is undesirable effect. You have to control it with your TAD or something.
Okay. There's a question, one question came up. Dr. Jojo Joseph. During perforation, any precautions to be taken with patient having diabetes and hypertension?
Like any dental act, you have to take precaution.
Perfect, perfect. Thank you so much.
Thank you.
We are getting a lot of good positive reviews as well. And in fact, today is a Sunday in India, and we have a parallel one of the webinar going on with one of our professor from Canada who happened to be an Indian but settled in Canada, and he's talking on COVID and orthodontics. But even then, more than 300 people join at a time, and then it's wonderful having all of you here. I would request our panelists to have some word about today's presentation.
Yes. First of all, thank you, Dr. Abdullah, for your amazing and valuable and informative lecture. And thank you for your effort in this lecture. I really admire with your philosophy in handling your case and diagnosing your case, especially the asymmetrical one. But I would like to talk about the sleep apnea. As you know, sleep apnea is not only a problem in the size or volume of the lumen. You may have some muscular or physical problem or neurological problem, especially we have some patients with loss of muscle tonicity of the upper airway. What is your opinion in diagnosing this case and handling this case? Is the only the uses of Marpe or the expansion of maxilla can solve this problem, or you may go to other way to in this problem? I would like to listen to your opinion regarding this issue.
يا أخي أشرف شرفت فيك الله يخليك. It's my pleasure to talk to you, Dean of جامعة الأزهر ما شاء الله. The answer is we are expanding the bone, and you are talking about soft tissue. The muscle of the palate, soft palate, with the age become loose and come down.
Yes.
Some turbinate or hypertrophy. The symptom nasal deviated. All this may block the air, but with the expanding, it hurts.
Yeah.
I have a lady of 71 years old, Dr. Ajay, remember? She has deviation of the symptom nasal, and by expanding the palate, expanding the nasal cavity inside, because don't forget that these TAD screw, they go inside the mucosa of the nose.
Yes, yes.
And when they expand the nasal cavity. So the problems of soft tissue inside the nasal cavity, that they are blocking the air, or behind the nasal cavity, that they are blocking the air, by expanding the area, help always better breathe. So the facial mask advance the mid-face. So in the back, the nasopharynx will increase in volume. And inside the nasal cavity increase. And in the mouth also the palate increase, and the tongue, which is usually close the airway, the throat, will have more space and will not go back often. And this is, so all from the nose until the oral pharynx, behind the oral pharynx, all is cleared by the Marpe, by expansion, not by removing. The lady with deviated symptom, I do not correct it. It's still not correct, but she get better breathing now. Okay, so these soft tissue that you talk about it, even if they stay, but because we are giving more space, the patient will see some progress in his case and his breathing.
Yeah.
Am I answered your question, my
yes,
dear professor?
Yes. There are some technical error. I lost your voice, but I understand from your explanation, which is very excellent, that you compensate any other problem.
Wait for me in Egypt, Cairo. I am coming. I will come visit Cairo too.
We wait you. And Dr. Ajay, I understand that you compensate any other problem with the increasing the volume by expansion. This is right?
No, you may get even the bite is almost edge to edge at the molar, and sometimes even you got scissor bite. But if the problem is apnea is very big, you don't mind.
Yes,
you see that. So as orthodontists, we tilting the molar, we changing the torque, we make something to touch to help, but our focus is to help him to breathe better.
The breathe, yes, which is very important than the occlusion, because the breathing is very important for all of the population all over the world.
Because some of my patients, they don't come themselves, their wives bring them.
Yeah.
There is no man that acknowledges that he is snoring, only his wife.
I look for the husband who is snoring, and he record a false result for your patient. In one case, you present increase after decreasing in the number of snoring, and then it get increased. This was the snoring of her husband.
Why it's increased? I was surprised, and then she said, "My husband is snoring."
So I try later on to sleep alone.
You can rather visit Dr. Abdul Hadi.
Other than sleeping alone.
Dr. Abdullah, I really admire with your hand skill in tackling the case of asymmetry, and your diagnostic aid. But let me to clarify the point of temporomandibular joint. I see you're diagnosing and see the increasing in size on one side and the decreasing in size on the other side. But did you expect a later on problem from the trying to correct the mandible by this way? Did you expect a problem, or did you expect? I know, as you answered, Dr. Ajayi, the patient age was about 15, 16, and the growth is still. But did you follow this patient, or from temporomandibular joint point of view, do you follow them or not? This is for me to learn about this issue.
Yes, I am going to follow them. This is a new. Don't forget that Marpe has only 5 years, so I am learning from myself, and I am experiencing things, and I am trying to. So it's everything is new, and everything. I have a patient. She has otitis, this cooling inflammation of the ears, and with the Marpe it disappeared. Now tell me what's happened. I don't know. I don't know. I have another patient. I showed it to you. A patient with paralysis facial, heavy facial paralysis, and disappeared. So tell me what's happened. I don't know what's happened. So I am. It's all new technique, is new experience, and I share with you all my experience. With the respect with Dr. Ajay, who helped me to share.
Sure, Dr. Abdul Hadi, because really I like your way in tackling this problem. So I hope to be in contact with Dr. Ajay later on after this webinar is finished, because sure we get benefit from your experience, Dr. Ajay experience. We get a lot of benefit, and at the end, for me, I would like to thank you too much again for your effort, and really wonderful. I like your way in tackling the asymmetry patient, and really I would like to listen again to your lecture, and I try to look it and watch it in YouTube or where is it, and I hope really after this COVID-19 is finished to meet together again with Dr. Ajayi and you and Dr. Khalid and all of you. Thank you at the end. Thank you too much.
Thank you, Professor.
I have no more comment, but really I thank the opportunity to be with you today, and thank Dr. Ajay for his invitation, and thank you for all of you. Thank you. I finished my comments.
It's our pleasure. It's a pleasure for us. It's really a pleasure for us.
Thank you. Thank you.
You know what? I know that how much effort it requires to conduct such a webinar consistently. Even when it takes a lot of time, a lot of efforts. So I respect you and Dr. Khalid for doing that, because it's a great help. It's a great help to everybody. It's a great thing to unite everybody, and that is how we are even spreading the brotherhood in the world, especially amongst the orthodontists. And this cannot be possible without people like Dr. Abdul Hadi and the other speakers. Without any personal, financial, or any other interest, they are sharing their vast knowledge with everybody in the world. They are sparing their time. I'm sure Dr. Abdul Hadi must have got up at around 5.
I have a very busy practice. You know, I have very busy practice, but I like to share my knowledge, and sharing my knowledge make me very happy. But I lose a lot of time with it, but it is a pleasure for me.
That's amazing. That's amazing. That's amazing.
Yeah. Yes. Thank you for all of you.
It was before COVID. Nobody had ever thought about such platform that we will be together and consistent.
Thank you.
Thank you, Dr. Ashraf.
So this is one of advantage of COVID-19. This is one of advantage that
they always say that necessity is the mother of invention.
Yeah.
Yes.
Right.
Yes.
It's right.
Thank you.
Okay, Dr. Khalid, I would really request if you can just have some word.
Thank you very much, Dr. Ajay, for this opportunity. It's really a great pleasure to be with you on this fruitful platform. I think you are benefiting a lot of people all over the world, not only in India, it's all over the world, spreading knowledge and providing this wonderful platform. And I'm grateful for the hero of today's webinar, Dr. Abdel Hadi, for presenting this fantastic webinar. I really benefited a lot. And what really I appreciate in your work is your thorough diagnosis. You know, you have told us that in the case of Asymmetry, he spent 5 years for treatment in another office. Okay. Yes. And I think these 5 years was actually due to lack of diagnosis. You have diagnosed everything in the case. You have actually done every diagnostic tool you have in order to customize the treatment plan, which actually didn't take a lot of time from you. I think I don't know how long does it take? Did it take with you? I think it took a lot. It's a little bit shorter than the 5 years spending in other offices. And this actually is accredited for your accuracy in diagnosis. And the end of your presentation was so marvelous that I'm contrasting before and after changes. And as you explained previously, this might be attributed to the remaining part of growth, as well as adaptability of the condylar head, in addition to the functional contributing factor. I think the asymmetry in the case was a little bit related to functional shifting, not only the skeletal one. Okay, because I think the remaining part which you couldn't achieve is that true skeletal asymmetry that needs surgery. But you have done a great job for this guy that you avoided him from being incorporated in a massive surgery by maxillary surgery. You have just a little bit surgery. So I'm just advising myself and all of the residents, Dr. Ajay, to spend the time in diagnosis and take time in diagnosis, because diagnosis saves time, saves material, as well as provide us with a brilliant ideas to be conducted. In addition to the sleep apnea, I think what's marvelous in your approach is that we have been taught in literature that sleep apnea is a multifactorial. It's not just a factor, one single factor. But, and in addition to this, you know that there is obligatory mouth breathing as well as habitual mouth breathing. What's the remark you have mentioned in your webinar is that all of your cases actually improved spontaneously. You didn't go to the phase of trying to help them to adapt to the new method of breathing. You know, you didn't use oral screens or some things like this. You just told us that spontaneously within few days, everything goes well, and they started breathing normally. Okay, I'm asking just a little bit, what do you think? Why this happens? You don't know it, you don't need for exercises, mouth breathing, and then training for nasal breathing. What do you think? I think this is a marvelous thing.
I think this revolutionary things that we expand the palate, we give more room to the nose and the mouth, and then we ask the patient to do exercise. It is wrong to ask a patient to do exercise without giving him the anatomy necessary for that exercise.
That's fine. So incorporate exercises in your practice.
And I ask, of course, all my patients should do at least 5 to 6 times a day, and every time 5 minutes of deep breathing until no more taking air from his nose, and then maximum expiration. So 5 minutes, 4 or 5 times every day. I told him, while you are driving your car, while you are waiting on the red sign, while you are watching TV, whatever, think about doing this, because if I expand and I give room and you do not use it, the soft tissue may grow and shut it again.
So you coin for the stability of your cases. So you are coining for the stability of your cases for the patients to adapt to the new mode of breathing. You have to function through this nose in order to keep the changes you have actually gained through the treatment.
You are right, Dr. Khalid. You have to exercise to keep the result that you get. If you do not exercise and you go back to mouth breathing, I think after 2-3 months, everything go back as it was by the soft tissue inside the nose, behind the mouth, the tonsils, everything grow up and will occupy the place that I give to you. So it's important exercise. So I ask my patient to walk in the morning if they can, and breathe 5 to 6 times a day, and every time for 4 or 5 minutes. Thank you for reminding me this, Khalid.
Okay, it's my pleasure. Thank you very much, Dr. Ajay, for the second time to providing me this opportunity, and thanks for all of the panelists. I'm grateful for you too, and thankful for being with you today. Thank you very much indeed, Dr. Abdel Hadi, for this kind remarks. Thank you.
It's an honor. You rightly said that good, like as you said, the one patient was waiting in another office for 5 years for orthodontic treatment, and it wasn't been done. So my sir always used to tell us when we were diagnosing that good beginning is half done, right? So always make sure, because many of the residents are listening to this. So key to this would be a good beginning, and good beginning happens only when you diagnose the case. And when you diagnose it correctly, I think you are halfway there through the treatment. And I would add upon the point, above every other points of getting a benefited from Marpe, I think it saves marriages also. He saved a lot of marriages, I think, matrimonial things also. That was the side advantage of it, right? You don't have to sleep separate. That's the best. Okay, I would request Dr. Mandava Prasad, please, if you can just share a few words.
Yeah, greetings all the panelists and Dr. Kawaya. Wonderful presentation, excellent presentation. Really, it's so made it so interesting, and we would all like to try it on some of the cases. Actually, we have a couple of cases now in the department, which we just started the Marpe to one case.
We will have Dr. Abdul Hadi very soon in India once the travel
Yes,
easy.
yes, we would like to.
I will have a long association with Dr. Abdul Hadi. We will disclose it little later.
Yes.
Yes, Ajay, yes.
I'm proud to be.
Yeah. Thank you very much. Thank you.
Thank you so much. Before I end, I would like to share the certificate which we have made for you, Dr. Abdul Hadi, and I would later on I would send it across to you.
Yes, please.
Right. I hope you're able to see it.
Oh, thank you. Very nice. Very nice.
And I must thank Dr. Khalid for helping me out in this, because I'm keeping so
My honor, pleasure. Thank you very much.
And I saw them doing it very nicely, so I just asked his help, and he helped me. And we have certificates for panelists also, and I would make sure that it has been delivered to your email. Okay, Dr. George Daba from Los Angeles.
Thank you very much, Dr. Ajaya.
Error, and you didn't get an email. So, and I was traveling in the afternoon, so I couldn't reply you.
I apologize. I apologize. Thank you. I would like to thank Dr. Abdel Hadi for this great presentation. I would like to thank you for inviting me. Thank you for all doctors attending, Dr. Ashraf, Dr. Khalid, Dr. Persad. Thank you very much. Before you finish, can I have a quick question for you, Dr. Abdul Hadi? Have you had this situation that you crank it 10 times in the office and you ask the patient to crank it for 4 days, 4 times or 5 times a day, and when the patient after 5 days came back to your office and you check the patient, you see nothing happened. You take CBCT and you see the screws bent to the side and the suture won't open. What you gonna do in this case? Before we start you start the webinar, I mentioned to you that many orthodontists, many oral surgeons here in Los Angeles got in this problem, in this situation?
You see, this situation, you may have it, and I have it in the beginning of my career with Marpe, is when you are scared to enter the Marpe until the end. When your Marpe do not go through the mucosa of the palate, of the nose. So how I know that my screw went inside the nasal cavity? I went, and during my turning my screw, I tell the patient, soon you will feel something stuck inside your nose. I turn and said to my patient, said, yes, now I feel something stuck that I want to take it out. I said, oh, I reached the nasal cavity. And then I continue turning, and I will tell the patient, after a few seconds, you will feel the tip of your nose start to numb. And I continue, and the patient said, oh, now it start to numb. It means that I reach the mucosa of the nose, where that little nerve walk. And this is my limit. What's happened for my, in the beginning of my career, I do a little bit and I stop, and I do not go through the cortical of the nose. And when it is, the screw doesn't go until the cortical of the nose, and inside the mucosa, it bend because it is short. It should go in full inside the nose, then it will not bend.
Now I get it. Thank you very much.
You are welcome.
Yeah. So, thank you very much. Thank you very much. Shukran. Shukran jazilan.
Welcome, welcome.
We have a very good feedback from one of our very eminent and senior orthodontists from India, Dr. Sunanda Roy Chaudhary, ma'am. She's saying great presentation, lovely records and documentation. Thank you, ma'am, for such a wonderful words. Thank you, Sunanda, ma'am. And thank you, everybody, for joining in. Right, it's a great pleasure and honor having you all. And probably for 2-3 days, we may not have a webinar because we are
relaxing.
Yeah, rather than relaxing, you know, we are slowly starting with the routine, right? And I've joined one course, so I also need to read something. So I need some time, but I would definitely come back to all of you.
They giving us webinar, and I will share with you another. I have another 2 webinars if you want about the Marpe. Inshallah, we share with you in the following 2-3 weeks again.
Yes,
we do another.
We will, and I wish that the first webinar which you shared with us, you share with Al Azhar as well.
Yes.
Right?
Yes. Yes.
You know, Al Azhar, they are my family because they are Arabic
You're
like
welcome.
me.
Yeah,
I know you have a very busy practice, but please spare time for them.
I see. I will do. I will do. I like them. I like Egypt.
Thank you. Thank you so much.
Thank you,
Dr.
for attending my lecture, and we'll see you soon. Thanks. A lot of thanks to Dr. Ajay and his team for his wonderful work to help us to reach each other. Thank you very much, Dr. Ajay. Thanks all the panelists, and have a good weekend. See you. Thanks.
See you all. Enjoy your Sunday. Bye-bye. Take care. Stay safe.
Goodbye. Thank you.
Salam.